Awesome. So let's chat about how to build effective community outreach and talk about engagement and clinical high risk for psychosis. This is a topic by popular demand. This was much requested when we had kind of sent out those surveys and the registration forms, and a lot of people had questions about outreach and how to engage folks in the community. I am delighted to announce that I have Dr. Friedman Yakubian, who comes from Massachusetts, and she will introduce herself when she starts her part of the presentation. And I have Dr. Kirsten Woodbury, who is coming from Maine. They are fantastic speakers. They've done some really cool work in their regions and their states. And I'm really excited to hear about what they're up to now. Next slide, please. All right, these are the learning objectives. We'll talk a little bit about the systems of care framework when it comes to the principles of community outreach and engagement. And we will talk about two examples of statewide outreach, that is Maine and Massachusetts. And we will, Dr. Heather Gotham will talk a little bit about, she's from Siemens, and she'll talk about audience mapping as a structured outreach tool and practice mapping referral sources. And at the end, we'll have breakout groups where we will kind of break out in smaller groups, talk about different techniques and strategies, and come back and share our experiences. Next slide, please. All right, so how do we use systems of care as a compass? Sometimes it's nice to go back to the mothership and kind of talk about, why we're doing this. SAMHSA strongly believes in the system of care approach, and sometimes kind of thinking about our outreach and engagement in the systems of care framework gives us a lot more bandwidth to think about it outside of, I just need referrals. So let's think about, how to go about doing it and like why we're doing this. Next slide, please. All right, so what is the systems of care approach? Of course, none of you is new to this, but just to kind of, review, revise, and kind of go back and jog our memory. Systems of care approach, it's a spectrum of effective community-based services and supports for children and youth with or at risk from mental health or other challenges and their families that is organized into a coordinated network, builds meaningful partnerships with families and youth, and addresses their unique needs in order to help them function better at home, in school, in community, and throughout their life. In words of Dr. Abram Rosenblatt, who is not here today, so kind of keep them in school, at home, and out of trouble. So, that is the short and long of it. And we, kind of looking back at this, like we do this every day or hope to do this every day. Maybe not in such a formalized way, but this is the larger compass. This is the larger goal. Next slide, please. All right, and the systems of care philosophy is something which all of us follow in our daily practice. It is family and youth driven, community based, and consists of systems of services that are responsive to individualized needs. And it's evidence informed practice and practice based evidence, linkage with mental health prevention and early identification, accountability, and developmentally appropriate services for both transitional age youth and young adults, as well as infants and young children and their families. So a lot of what we do is based out of this. So a lot of what we do is embedded in the community, and kind of thinking about your local community in this framework goes a long way. I'll give you an example of my program. I'm from Pittsburgh, and we kind of, mapped out our community in the following fashion. Next slide, please. But this is pretty much what you can do in any community. So broad principles, find youth and families where they are. We need to move away from our hierarchical kind of ivory academic tower structures. Find young people, find the families where they are, really getting into the grassroots, kind of finding the grassroots approach. Depending on, what your community looks like, it is really important to think about like a broader approach versus like a targeted approach for people who would be at higher risk. Of course, the services and the outreach and as well as the engagement needs to be developmentally appropriate for the audience and the youth that we're hoping to provide services to. our attitudes go a long way into, just making people in the community feel comfortable about talking about some of the hard stuff that they're going through. And as a result, how you would be presenting this state or clinical high risk goes a long way into their comfort in sending back referrals to you. And just kind of being creative, partnering with what you have in the community. I strongly believe that each community has a lot of strengths, and finding those strengths are important. Next slide. Thank you. This is just an example of kind of how to think about broader community, and some of these are kind of higher acuity, higher risk situations, such as, higher level of care, ER, crises, and some of them are kind of, broader kind of preventative approach. So schools, colleges, kind of family fairs, health fairs, YMCA, churches, back to school nights. These are just examples of different programs that you can kind of think about in your community. Next slide, please. All right. Handing this over to you, Dr. Freeman Cubian, Massachusetts, is going to talk.
Fantastic. Thank you so much. And I just love want to start by just expressing appreciation for this effort. I think, oh, wait a second, I want to switch my view. All of a sudden, all I could see is myself and not all of your beautiful faces. And that made me very nervous. Okay, now it's fixed. But when I was really reflecting on, and I think it's very fitting that Dr. Woodbury is coming right after me, because really, when we were starting our program in Massachusetts, Dr. Woodbury was instrumental in teaching us how to do this. And so pretty much everything I'm going to present is stuff that she taught us and that we benefited from, and love how much this field has grown since 2009, when the Cedar Clinic started and we started doing this work in Massachusetts, and how all of you don't have to reinvent the wheel and kind of start from scratch. You can learn from folks that have been doing this work and benefit from some of the lessons that we've learned along the way. Next slide. So just general take-home message. If there's one thing that you remember, outreach isn't just about increasing referrals. It's about building a community that recognizes early psychosis and knows how to respond. So it's working with the community, and it's connecting, and it's educating the community as a group and building relationships. Next slide. So here's a little bit of a timeline of our journey, and I'm also very grateful that Amanda Weber is here today to kind of take on talking about some of the later stages in this journey. But just to give you some context, we've had the great privilege of being involved in doing early psychosis work for quite a while. Our first episode clinic started in 2003. Cedar Clinic was very much kind of modeled in some ways after the PrEP program, and started in 2009 with some efforts kind of starting as far back as 2006, 2007 through research. The focus over, the last many years of the program is really relationship building, right? So when it comes to referrals, it's helping people in the community that are going to come in contact with kids and families who are in need of our services to be able to know who we are, what we do, and how to reach us at the right time. And that's really about building relationships. So in 2017, MapNet, which is the Massachusetts Early Psychosis Network, was developed, and that was a statewide first episode psychosis training, technical assistance, fidelity, and workforce network. And that created some infrastructure by which I think our CHRp initiatives have really benefited. And from about 2009 to 2020, Cedar Clinic was the only clinical high risk for psychosis clinic in Massachusetts. And my colleagues from STAR and Reset that are here, correct me if I got these wrong, but McLean and MGH, STAR and Reset, and Emily Carroll and Lauren Utter are here representing those programs, started in the early 2020s. And in 2022, we were lucky to get one of the SAMHSA Clinical High Risk for Psychosis Program grants, which helped us to launch our statewide network and learning collaborative. And that's really where we started to centralize outreach, consultation, triage, and referral in the development of the empath program. Next slide. Thank you. If folks are interested in checking out a paper about the origins of CHRp, feel free to check this one out. But we kind of really talked about some of the lessons learned from CHRp, which was really a public academic partnership. So there was a correlation, a connection between research and the Massachusetts Mental Health Center, which is the original home for the CHRp Clinic. And within that paper, we talked about kind of 4 A's that are foundational for outreach. So the first A stands for awareness, which is really just helping providers recognize early warning signs of psychosis, to understand what they are, how to respond to them in a way that is hopeful and supportive versus afraid and overwhelmed and focused on risk and really kind of providing a path. Second A is availability, making sure people know that specialized care existed. So in those early days, not only do we do, things to increase awareness, like, I had an opportunity to go to almost, I contacted every college counseling center in the area. I think Kristen Woodbury was contacting all of the primary care in the area. And we went out, we did talks, and we said, if there's just one thing that you remember from this talk today, it's my phone number. If you have a kid that you're worried about that might be experiencing early signs of psychosis, just give us a call and we will figure out what we can do. And we made an effort to be available when they needed us in order to be able to think things through. Third A is activate referrals. So of course, we want to address myths, stigma, and uncertainty about psychosis. So a lot of those early talks, I would ask college counseling center clinicians, do you screen for psychosis? And most of them said no. And I said, if you did sort of ask people about psychosis, how confident would you feel about what to do if someone endorsed some experiences of hearing voices and other things? And lots of folks expressed worry. They don't want to ask about it because they don't want to stigmatize folks. And they also wouldn't know what to do if people were hearing voices or experiencing early signs. So a lot of our outreach is about helping people feel more comfortable about knowing what the resources are, what the supports are, and addressing some of the stigma. And then access. So we really wanted to make sure families could easily reach care once we were ready. So that meant doing everything we could to make availability of appointments as quick as possible so that we could support people where they are. Next slide. Okay, so, again, outreach is relationship building. Really our most effective outreach strategy wasn't our brochures, or the things that we provided or anything especially exciting that we said in our outreach talks. It was really, if somebody came and they met with us and they had a good experience and we let the referrer know that we appreciated them connecting us and that it worked out, they sent us more referrals. They were really happy with the experience, and that's how you build your program. So, all kinds of things, including just providing free consultation, responsive phone calls. A lot of times we would say things like, if you have a kid in a family you're worried about, give us a call and we'll think through with you the best way to connect that kid with us. Maybe it's just giving them a brochure, but maybe even better would be calling us from your meeting and making a warm connection to one of our clinicians at that time who can say hi and kind of help with the next step of scheduling an appointment. So really kind of thinking about being flexible in our connections. Another huge part of outreach was incorporating lived experience speakers into our outreach. So in our early days of outreach, Brooke Katz was a wonderful, wonderful speaker who shared her own experience of early psychosis and what that was like in the many years that she experienced symptoms in a system that didn't recognize those symptoms, and also shared her path of hope and recovery. And that was something that made a lasting impact in a way that me, as a clinician working in this space, could never make. And so really having a lot of time, and currently within our empath outreach presentations, we have some really wonderful people who are sharing their lived experience and their family lived experience. And that goes a huge way in addressing stigma and helping people feel comfortable with making referrals and understanding what we're trying to do. Next slide. So here's a challenge that started to come up as we grew, right? So we started to have 3 clinics instead of 1. And we had situations, right, where folks would call all 3 clinics or get confused about all 3 clinics. So, we have one, example where a pediatric practice was contacted separately by all 3 of us, offering to do an outreach talk and sharing contact information, which is overloading and leading to not calling anyone. Or families calling 3 clinics, repeating the same intake questions each time, and nearly giving up. All 3 clinics spending staff time evaluating a client who could only be seen once, right? So we'll go into next slide. Okay, so this really led to the solution of empath, which I think I should maybe, Amanda, do you want to take it up from here?
Oh, sure. So yes, this led to the development of empath, which essentially is trying to take some of that load that Michelle was talking about around the outreach, the consultation, the training the providers out there, trying to take some of that load off of our clinics, and also trying to centralize a message in one place for folks to come through and then to disseminate out, so that people aren't feeling like, wait, which clinic do I call? Do I know? Am I sure I should be making this referral? And making sure that we have a singular message that we're trying to train all of the providers, school people, pretty much anybody on what is early psychosis and what do we mean and where can you get the help. So next slide. In essence, the goal of empath is really to shorten the duration of untreated psychosis by connecting people to where they should or need to go as quickly as possible. I'm sure you all know the people who have been like, I didn't know you existed, or I wasn't sure, or I sent my referral to this clinic, but they never got back to me, or, that I never was able to follow up with the voicemail, whatever. Empath is really about holding that person's hand until they can get to the most appropriate care. So empath does a variety of things. We do a significant amount of outreach and education, and we use what empath has sort of termed as their own psychosis-informed care. It's a set curriculum and it's a set training that we provide to a variety of people, which I'll talk about in a little bit. We also do screening and referrals. So if someone sends a referral to us, we give them a call within 48 hours, more like 23 hours, but we're supposed to do it in 48. We screen them. We say, hey, this might actually be better for a clinical high-risk program. This might be better for a first episode program, or you might need something out in the community because you've had psychosis symptoms for a little bit. We do bridging and follow-up so we can make sure that person gets to the care. And we also do free consultations to mental health providers, pediatricians. So they give us a call. They're like, we don't actually want to send this person on, but we want to hear a little bit about your expertise. Next slide. Again, this is sort of saying the same thing. We have services for providers, but we also have services for young adults and families Our young adults and families, we access resources for them. We help with care coordination. We have a family partner who works with parents and caregivers to help access resources as well as just provide that warm support. And we have a peer mentor who helps youth connect to peer services as well as meets with any youth that wants to and can talk about her own experience of what it means to engage with the mental health system. Next slide. I know I have like 1 second left. These are the lovely people who do a lot of our clinical consultation and our administrative referrals. Next slide. This is our peer. She is one of the most powerful speakers. The other thing that I forgot to include is she also speaks in our trainings to providers. There's nothing better than getting a lived experience voice in a clinical consultation or a training. Next slide. And this is our family partner. Super lovely, also has lived experience, a young person with psychosis, and he uses his experience to really connect with our caregivers who are feeling hopeless, feeling a lot of despair, and not sure exactly where to connect. Next slide. Okay. Here are some of the places that we are connecting with. So we do intentional outreach to DCF, DYS, a lot of youth-facing organizations. We connect to a lot of pediatric and primary care settings. We're doing a trial of what we call clinical champions at community health centers here in Massachusetts, where they engage in a 12-month curriculum where one person or potentially two people, usually the behavioral health provider, become more experts in early psychosis and then can be that consultant, in-house consultant to the pediatricians and any provider, hopefully to create a more sustainable model, like a public sustainable health model. Next slide. Okay, I'll leave you all here because I know my time's up and I know Michelle and I's time's up, so thank you.
Thank you all. That was lovely. Thank you, Amanda. Thank you, Michelle. I'll hand it over to Dr. Woodbury. I am sure a lot of you have a lot of questions. We will try and answer them after Dr. Woodbury's presentation.
So, hi, everybody. It's wonderful to follow that presentation because they really provide, I think, some of the important nuts and bolts. I'm a clinical psychologist. I work at Maine Health Institute for Research. You can go to the next slide. And I work closely with the peer program. I'm going to be talking about primary care, but a bulk of this is with integrated care. So our focus is on the behavioral health clinicians who work hopefully in a team-based collaborative care model. And I'm going to include some practical resources and also a vision for the future. Next. I don't have conflicts of interest, but this is public and private funded. Thank you. Next. And the vision really isn't just to advance community awareness, but I really am interested in normalizing screening for psychosis. Next. And this is the feedback that we've gotten. I'm sure you've heard some of this kind of feedback. It's real. I get it. But my hope today is to next make a case for, go ahead to the next, there's animation. Why screen, why primary care, and why the CME model. So I'm going to talk about that specifically next. So this is a graph that's probably familiar in its general sense. The y-axis is functioning, with higher being better. The x-axis is age, with the teal bar in the middle being the age of peak risk. And all of us here, I think, are in the clinical high risk area. Our goal is the teal line. We're trying to improve outcomes and avoid the classic kind of course of psychosis, which is the red line. And importantly, next, our message here is that recovery is a goal. So one of the key messages we have is that there's a critical window. There's evidence that timing matters. Part of this is developmental, both biological and social. Next. Some of this is the fact that the months right before and after psychosis onset present particular vulnerability for suicide, violence, hospitalizations. Next. And that timing makes a difference really in both personal and societal outcomes. Next. But here's the thing, our current strategies come up short. And current strategies tend to be outreach and education to help community members recognize the early warning signs, call us if they need help, understand where to go. These effects have low sensitivity so that we're failing to identify enough of the right people in time. Most people are coming to us after a first episode of psychosis, and low specificity in we're identifying, and pardon me for using the word wrong here, but we're identifying people for whom our services are not necessarily the right pathway. Next. So the CME idea is really, can we screen for psychosis to improve sensitivity, triage positive screens, because if we refer all positive screens, our services are going to be overwhelmed, and we're going to, again, be directing people to the wrong kind of care. And then third, to connect better the people that the community recognizes or individual recognize to early intervention. Next. So I'm going to make the case for why primary care was a sensitivity issue. Next. This really is the place where health prevention early detection is centered in our health system. There's lower stigma than mental health cares, and there's growing integrated care. Next. It's also the most likely point of care for some of the early non-specific symptoms, so insomnia, inattention, and some of the longitudinal relationships may increase awareness of things like family history of mental illness, insidious onset, or other risk factors or indicators. Next. And primary care is trained to recognize and diagnose syndromes, which I find really helpful in terms of conveying clinical high risk as a syndrome. And there's some evidence that medical visits increase in the 3 to 6 months prior to psychosis diagnosis. Next. So gratefully, there's some really fascinating international research that suggests that educating primary care and integrating with mental health services can address some of the barriers like inadequate knowledge, insufficient access. Next. Interestingly, there's a fabulous study by Ian Falloon that suggested that the screening checklists on the right, in combination with rapid access in integrated care, was actually associated with reduced incidence of schizophrenia. Next. So, working in Boston, again, with Michelle and others there, and key pediatric primary care partners, we began engaging a professional designer to develop a website and booklets, hard copy booklets. Next. The idea really, again, was this kind of traditional outreach model of knowing the signs, so recognizing early warning signs, importantly, finding the words to talk about it and making the connection to the care. Next. Like most outreach, again, we tried to educate not just on positive, attenuated positive symptoms, but really the early negative symptoms, changes in cognition, social behavior, speech. Next. We also really emphasized this part, which I know Michelle touched on, but which is really moving people from fear of, if I ask this question, what do I do with the answer, to helping them be curious and feel like they can use their natural skills of being able to ask about someone's experience and get more details and better understand what someone's talking about. Next. Then our primary care partners really helped us develop a pathway, so different paths for individuals who have different kinds of responses to those questions. This, again, is all available on our website. Next. And we have a flow chart, and importantly, this was our start. This used age, so you can see we were targeting adolescents and adults up to age 35. And we were asking people to consider, and this is again typically considered selective or indicated screening, people who have some kind of change in their mental health or their functioning or cognitive status. And then we guide them through how to decide what pathway to follow. Next. So we distributed these hard copy booklets to all of the pediatric practices in Massachusetts using the Psychiatry Access Project. We provided webinars. We got wonderful reception. People were excited to have this information. We got little real impact on referrals. Next. And our conclusion from this, which was, humbling, was really that this indicated screening, expecting people to notice the signs and then screen, is insufficient. Next. So we went ahead to test the CME model, screening for early emerging mental experiences, but again, making the emphasis that we want people to see these individuals. Next. And this is a complex visual, but really what we're trying to do is leverage the second image from the left, the primary care visit, where someone comes in with some kind of complaint of insomnia, inattention, and care as usual leads people to pathways we're quite familiar with, which are long, aversive, and if they're lucky, lead to care. What we're trying to do is the lower path and leverage primary care practitioners, but really encouraging them to refer to their integrated mental health clinicians so that they can do the screening, the triage, and the engagement that the primary care clearly don't have time to do. Again, this takes warm handoff, so the integration of these professionals in care is pretty critical. Next. So this is our model. Again, screen, triage, engage, matches with know the signs, find the words, make the connection. And what we're really emphasizing is being able to have sensitivity. We're capturing as many individuals as possible, but then really narrowing in on the people who need specialized care, which is only path 3 here. Next. So feasibility, will practices and providers participate? Next. The answer is yes, in COVID, no less. And next. What type of screening is feasible? Next, we actually tested universal, selective, and indicated and got good results. Next. Importantly, how well do mental health clinicians triage? I'm really excited this is getting tested in Massachusetts. In our experience, we had of those people who screened positive, this is going to be a large portion of your mental health population. We had 10% referred to peer, and I think that's the right ballpark. So this is 5% of all the young people who were screened, 10% were referred to specialty care. Next. I think importantly in this model, there were about a third of individuals who are going to be monitored. So these are people with more sub-threshold symptoms, but because they're being monitored, the clinicians are ready to respond if things progress and worsen. And they've given some education to the patients on what to look for. Next. So we've really found that this trained clinicians to improve specificity, and we expect sensitivity as well. Next. So the preliminary findings from our feasibility trial was it appears feasible. Next, we really thought that it helped with early detection, so that sensitivity of finding people. Next, the referrals jumped to our peer program, and importantly, those who were referred from our CME sites had fewer prior hospitalizations and ED visits, supporting gentler pathways. Next. We thought the clinicians did extremely well in triaging trauma and developmental disorders and anxiety. Next. And the area that really is highlighted that we still need to improve is this linkage to care. So getting people from primary and integrated care into specialized care. Next. Takeaways from 10 years of this work. I think imperfect screening is better than no screening. I think we need to prioritize screening items that are easy to read and understand. Next, the care decisions, including referrals, really need to not be based on a positive screen alone. We need clinicians to be able to ask about that. Next. We're going to go through all of these, please, the animations. So we really need to balance active and thoughtful action, curiosity and hope, and collaborative and practical problem solving with our referral sources. Next. This was not my work alone. This really took a village. Next. And I'm happy to take a few questions. I think I have a couple minutes.
That was lovely. Thank you both. And as someone kind of really nicely put it in chat, I think we're moving away from fear and stigma to curiosity and humility. Thank you for that.
Rashida, I'm up next.
Yes.
Great, thank you. We can
Thank you.
advance the slide. Thank you so much, Kristen and Michelle and Amanda. We are running a few minutes late, so we're not going to take questions right now, but there will be some time after the breakouts. And if you want to put questions in the chat, I know everyone is happy to respond there as well. I so appreciate all of the comments about how do you build outreach and engagement? How do you pull your referral sources in? And based on those topics and the presentations we just had, we're going to turn things a little bit to what can you do to build your audience and specifically to build your referral sources, in addition to the great examples I think that were provided already. So next slide. So I want to talk a little bit about audience mapping. And again, hopefully you can see the threads from what was just presented to where we're going to go here. So just a couple slides about how do you focus your effort where it matters most when you start thinking about, wow, we really need to build outreach and engagement pathways. We need to build our referral sources. We want to think about tailoring your message to your specific audience. So this is going to sound like communications and marketing because it is. But that's okay. We are not marketing, for profit, goodness knows. We are marketing to provide important services, which is also called social communication. So we want to think about who needs personalized messages, who needs regular updates, what information do these potential referral sources need, who needs to build relationships first. I'm sure you have some referral sources where you're like, once they know about us, then they will refer to us, other folks who need to build that relationship and trust. I think that in the presentation that we just had from Kristen, she talked about like we did education and it didn't work. So we had to kind of go back and do things a little bit differently. So just knowing about a service doesn't mean that that's going to help people to actually change and reach out. So next slide.
So before we craft a message or choose a platform on which we're going to share and communicate, we need to understand who we're speaking to. So if you start thinking about your audience, knowing that audience and knowing it well helps you create more resonant messages, helps to avoid some assumptions or missteps, which in our business of providing services to people can really lead to mistrust, which none of us want. Can help build authentic relationships and can improve trust. And from trust, we get closer to action. Next slide. So just have you for a second think of one group you're trying to reach and what's the one thing that your audience cares most about. So if you think about a referral partner or someone who's going to do outreach, I'm thinking back to the slide that Michelle and Amanda presented on all the different outreach partners they had. What's one thing that your audience cares about most? Do they care about not having a wait list? Do they care about trusting the services you're providing? Do they care about wanting at least one person that they can call and they know that they're not going to go to like a phone tree, but they're going to go to an actual person who can speak to them? Do they care about what is it that they care about? And so that's where we're starting to in this portion to have you start thinking about. Next slide. And that one thing that you think your referral source might be concerned about might be what they're concerned about, but there also might be these things that are kind of underneath. So beliefs, motivations, fears, concerns about access, burnout of the folks that you're trying to engage to provide referrals to you. And so thinking at this like deeper level of understanding can help avoid messaging that might be tone deaf or ineffective. Next slide. So we want to have you think about the why behind the action or inaction. Think about what are the barriers and benefits that a particular, in this case, referral source might be considering. So again, barriers are factors that block trust or access or motivation. Benefits are things that the other person or organization values or things that they think they're going to gain from engaging. And to be pretty strategic and thoughtful about how we do this. So again, that thinking about barriers and benefits and what we're going to do is to try to map those helps you create a clear message tailored to what your audience actually needs and values. Next slide. So here are some of the barriers and benefits. They may or may not resonate with you, but you could certainly think about barriers like all of the silos that our different healthcare pieces are in, from primary care to behavioral health services to child welfare and other services. Those can be barriers that people find it difficult to cross. Stigma about the services that you're providing or concerns from family members about stigma associated with particular diagnoses. Again, we are a country that is burned out, and it's hard to build trust when we're in this what seems like sometimes perpetual kind of state of burnout. But there are benefits from engaging in your services and benefits that you want to make sure that your audience understands. Next slide. Okay, so we're going to talk about tailoring your messaging. So when you tailor messaging around barriers and benefits, you want to name the barrier, you want to highlight the benefit, and then craft a message that addresses the barrier and offers the benefit. And I know this example, I apologize, is not probably the most important example that you might be thinking of. This is about wait lists, and that's probably not what you're about. But you can see in this example that it states the barrier. This is worrying about referring your clients because they'll end up on a waiting list, but it highlights the benefit. We offer walk-in intakes 3 days per week. So you can think about, again, crafting a message that combines those things, which can be really powerful and really speak to your audience. Next slide. So Judith has put the link in the chat for our breakout group activity. We're going to have about 10 minutes in the breakouts today. And the next slide is going to walk us through what the breakout's going to look like. We don't have 20 minutes, we have 10 minutes, but so we want you to start to map your referral sources or talk amongst yourselves about mapping referral sources. So think about the partners that you want to reach, what matters to those organizations and what might keep them from referring. So think about the barriers and benefits. Who are the key people in those organizations to connect with? What are some of the best ways to build and maintain those relationships? So Amanda talked about that great program where they, over the course of, I think, 12 months, she said, help build kind of champions. That's a great way to build relationships. There's other things, you know, you do a lunch and learn, you take someone out to lunch, you meet for coffee, whatever it is that you need to do. So next slide. In your breakout, if you can identify note takers, a note taker, and someone to do report out. I'm also hearing we're going to give folks 15 minutes for this. So 15 minutes, here's the activity. And so again, want to have people start thinking about the partners, the benefits and barriers, who to reach out to, current relationships. So this is something you can take back to your team also after today and work out some of the details. But I hope that the discussion is fruitful, talking about benefits and barriers in particular. And we're going to stop the recording, please, Judith. And we will